that sudden chest pain?
Yeah.
Is it just anxiety or something more serious?
Yeah, or that feeling of your heart racing for seemingly no reason.
Exactly. And you wonder, would you even know if something was really wrong? It's unsettling, right?
It really is. Understanding those signals is so important.
So today, we're diving deep into acute coronary syndromes, what they actually are, how doctors spot them, and what the very latest science says about managing them.
Welcome to the Deep Dive. We're the show that takes complex medical info and pulls out the key insights you need.
And our focus today is a really significant piece of guidance. The 2025 ACS-NAMS-PSCI Guideline for the Management of Patients with Acute Coronary Syndromes.
Think of it as the newest, most comprehensive roadmap for these critical heart conditions.
It really pulls everything together.
It does. This guideline consolidates and updates recommendations from several older ones. It builds on the 2013 STEMI guideline, the 2014 NSTE-ACS guideline, and the 2015 focused update on primary PCI for STEMI. And importantly, it also replaces the guidance on dual antiplatelet therapy duration from the 2016 focused update. That's now covered by the 2021 revascularization guideline.
Right, keeping everything current. Now, before we jump in, we really want to give a special thanks to London Heartbeat Z Academy UK for their educational support for this deep dive.
Yes, definitely.
They offer a fantastic range, over 150 courses, so do check those out. And you can find them on Facebook, Instagram, YouTube for free regular updates. Don't miss their future discussions.
Great resource. So our mission today is really to unpack this extensive guideline for you.
Yeah, break it down.
We'll cover what ACS actually is, how it's evaluated both, before the hospital and once you arrive, and the key management strategies.
The goal is for you to walk away with a solid understanding of what's most important.
Exactly.
And just to be super clear, we are sticking strictly to the information within this 2025 guideline.
That's right. No outside studies, no personal opinions, and definitely keeping away from any politically charged stuff.
Our job is just to report impartially on what the guideline says. We won't be quoting authors directly either.
Okay, so what's the plan? Where are we heading in this deep dive?
All right, so first we'll define ACS, then initial assessment, pre-hospital and in-hospital, risk stratification, how doctors figure out the level of danger.
Crucial step.
Then the standard medical therapies. After that, reperfusion strategies, specifically for STEMI.
Okay.
Then managing NSTE-ACS, the other main type. We'll look at cath lab considerations, the serious issue of cardiogenic shock, and other ACS complications.
Right.
Plus some in-hospital stuff like discharge planning, how long to stay on antiplatelets, and a few other therapies mentioned.
Sounds like a comprehensive plan. Let's start with the basics then. What exactly is an acute coronary syndrome?
Good question. Think about the arteries supplying blood to your heart muscle.
The coronary arteries.
Right. Over time, you can get buildup of fatty deposits plaque. That's atherosclerosis. And ACS usually happens when one of these plaques suddenly breaks open or erodes.
Okay, so the plaque becomes unstable.
Exactly. And when that happens, it triggers a blood clot, a thrombus, right at that spot. Figure 1 in the guideline actually shows this pretty well for a type 1 MI.
Right, the plaque rupture leading to the clot. That buildup of fats and inflammation makes them fragile.
Yeah. And if that clot gets big enough to seriously block blood flow in one of those main heart arteries,
then the heart muscle doesn't get enough oxygen, ischemia.
And if that lasts too long, the heart muscle cells start to die. That's a myocardial infarction or heart attack.
So ACS isn't just one single thing, it's more like a spectrum.
Precisely. The guideline classifies ACS into 3 main buckets. Unstable angina and STEMI, that's non-ST segment elevation MI.
Okay.
And STEMI, which is ST segment elevation MI. They represent different severities of blockage and damage.
Got it. I've also heard about the universal definition of MI. How does that fit in?
Yeah, the guideline touches on that. It clarifies that this 2025 guideline mainly focuses on type 1 MI.
Which is the one caused by that plaque rupture and clot we just talked about.
Exactly. Acute coronary atherothrombosis. But the guideline does acknowledge it can sometimes be tricky telling a type 1 from a type 2 MI. Table 4 actually outlines the different types.
Right. Type 2 is more about an oxygen supply-demand mismatch, not a primary clot blocking the artery, correct? Like severe anemia or maybe a super fast heart rate in someone with existing disease.
Yeah, exactly. So if it's not immediately clear, doctors might initially treat it as ACS just to be safe, depending on the situation.
Okay. And type 3 MI is mentioned too?
Briefly, yeah. That's when someone has sudden cardiac death with symptoms suggesting an MI, but maybe blood tests weren't done or available to confirm it.
I see. So unstable angina and STEMI, all under the ACS umbrella, mostly type 1. What's the key difference electrically, especially between NSTE-ACS and STEMI?
The ECG, the electrocardiogram, is usually where you see the main differences. Table 3 summarizes this.
Okay.
For NSTE-ACS, which covers both unstable angina and NSTEMI, you might see new changes like ST segment depression, where that baseline tracing drops down. Or maybe T-wave inversion, where a wave flips upside down. Suggests the heart isn't getting enough oxygen, sometimes even brief ST elevation that resolves.
But crucially, no persistent, significant ST elevation like in STEMI.
Exactly. That's the defining feature of STEMI. You see new, significant elevation of that ST segment on the ECG.
And there are specific criteria for how much elevation, right?
Yes, the guideline lays them out. Generally 1 millimeter or more in at least 2 connected leads. But in leads V2 and V3, looking at the front of the heart, it's a bit higher.
Right, depends on age and sex, too.
Yeah, 2 millimeter for men, 40 plus men, 2.5 millimeters for men under 40, and 1.5 millimeters for women. This persistent elevation strongly suggests a coronary artery is completely blocked. Big trouble.
Okay, that clarifies the ECG differences. So that initial ECG is paramount. Let's talk about that initial evaluation, starting even before the hospital.
Absolutely critical. The pre-hospital phase. Recommendation 1CLD2 really hammers this home. Get a 12-lead ECG and have trained the EMS interpreted ASAP, ideally within 10 minutes of first medical contact or FMC.
And that makes a real difference.
Huge difference. Studies show it leads to faster reperfusion times, getting the artery opened, and lower death rates for STEMI, if that info is used to guide care, like heading straight to the right hospital.
So trained paramedics can actually diagnose a STEMI in the field from the ECG.
They can be very accurate, yes.
Yeah.
And if they see that clear ST elevation or an equivalent pattern,
they should start the STEMI protocol right away.
Exactly.
Yeah.
No delay. But remember, for NSTE-ACS, you don't necessarily need ECG changes right then.
Got it. What else is key in the pre-hospital setting?
Identifying the highest risk patients early on. People with signs of heart failure, dangerous heart rhythms like ventricular arrhythmias or cardiogenic shock.
Where the heart just can't pump enough blood?
Right. Those patients, if possible, need to go directly to a hospital equipped for PCI, the artery opening procedure. Recognizing those complications early is vital.
Okay, so early ECG, STEMI activation if needed, identify high-risk patients. What happens when they reach the hospital?
The focus on speed continues. Recommendation 1 BNR1 says get another 12-lead ECG and have it interpreted within 10 minutes of arrival in the emergency department.
Confirm the findings, guide the next steps immediately.
But what if that first hospital ECG looks normal or non-diagnostic?
That doesn't mean they're in the clear.
Right. Absolutely not. Recommendation 1 BNR2 stresses this. A non-diagnostic initial ECG does not rule out ACS.
Things can change quickly.
They can. So compare it to old ECGs if available. And crucially, do serial ECGs. Repeat them, especially if you have high suspicion based on symptoms, or if their pain persists or their condition worsens.
Keep monitoring that electrical activity.
Yes. And consider right-sided leads for suspected inferior MI or posterior leads if you see ST depression in V1 and V3, which might indicate a posterior STEMI.
Okay, so repeated ECGs are key. What about blood tests, the cardiac enzymes?
Right, cardiac troponin or CTN. Recommendation 1 BNR3 says measure it ASAP in suspected ACS, preferably using the high-sensitivity assays, HSCTN.
Because troponin leaks out when heart muscle is damaged.
Precisely. And the high-sensitivity tests are really good at detecting even small amounts of damage. Vital for diagnosis.
But you don't wait for the troponin results if the ECG screams STEMI, do you?
Absolutely not. That's a crucial point. Reperfusion therapy for STEMI should not be delayed waiting for biomarker results.
Okay. And a positive troponin is defined as being above the 99th percentile.
Correct. Above the upper reference limit for that specific lab's assay. Higher than 99% of healthy individuals.
So ECG first, then troponin to help confirm damage, unless it's a clear STEMI.
That's the general flow. And start initial medical treatment immediately for presumed ACS. Don't wait for all results.
Okay. What about imaging, like an echocardiogram?
Urgent echo and ultrasound of the heart is needed for patients in shock, unstable, or if you suspect a mechanical complication, like a tear or valve problem. Maybe even a quick point-of-care ultrasound initially.
But again, for suspected STEMI, don't delay reperfusion with extra tests unless it immediately changes the plan.
Right. Get that artery open.
What about those patients without a clear STEMI? Maybe initial troponin is okay. How do you confirm or rule out an NSTE-ACS then?
Good question. Further testing depends on the whole picture. History, ECG, biomarkers. patient preference, ability to exercise.
Uh-huh.
The guideline strongly recommends using evidence-based clinical decision pathways, or CDPs, like step-by-step guides.
To standardize the process.
Yeah, and studies show they improve outcomes and resource use. They help avoid unnecessary tests while still being good at ruling out major problems. Figure 3 shows an example pathway.
It makes sense, a structured approach. Now, once ACS is suspected or confirmed, you mentioned risk stratification. What's that about?
It's basically figuring out how likely a patient is to have a bad outcome soon, like death or another heart attack.
Okay, assessing their individual risk level.
Exactly. It helps guide treatment intensity, informs discussions with patients and families. How aggressive do we need to be?
Are there specific tools for this? Risk scores?
Yes, the guideline mentions several, but specifically highlights the GRACE score Global Registry of Acute Coronary Events and the TI score Thrombolysis in myocardial infarction.
Okay.
These are well validated for both NSTE-ACS and STEMI. Table 5 lists them. They use readily available info, age, heart rate, blood pressure, kidney function, signs of heart failure, ECG changes, troponin levels.
Things you'd know fairly early on.
Right. And they help decide, for instance, if an NSTE-ACS patient needs an early invasive strategy, go into the cath lab sooner rather than later.
But they're for assessing risk after suspecting ACS, not for diagnosing it initially.
Correct. And studies show GRACE, for example, is better than just a doctor's gut feeling at predicting death or MI and STEMI or intermediate risk NSTE-ACS.
It's interesting. More objective.
It is. But the guideline also notes we don't have solid proof yet that routinely using these scores in every hospitalized ACS patient actually reduces future cardiac events. They're helpful tools, but part of a bigger picture.
Okay. What are the big factors driving risk in these scores?
Signs of heart failure, like fluid in the lungs, that's a big one. Part of the Killip classification, which feeds into GRACE and TMI.
Right.
Elevated cardiac biomarkers, like troponin, are also key. Higher levels generally mean higher risk.
Makes sense. More damage, more risk.
Other markers like natriuretic peptides, BNP, or NT-proBNP can also add prognostic info about risk of death or heart failure.
What about the really sick patients, those in cardiogenic shock? How does risk stratification work there?
Recognizing shock early, even pre-hospital, is critical for triage and understanding their extremely high risk.
It carries a very high mortality rate, doesn't it?
Sadly, yes, around 7 to 10% of ACS patients develop it, and mortality is high. Rapid revascularization opening the artery improves survival.
So getting them to a PCI-capable center, maybe one with advanced support like MCS, is vital.
Absolutely. And there are scales to assess shock severity, too, which correlate with outcomes.
Let's shift to another critical situation. Cardiac arrest. How does that change ACS management?
Yeah, about 10% of STEMI patients transferred by EMS have had an out-of-hospital cardiac arrest.
Wow, that's significant.
It is. For those resuscitated, their heart is beating again, early STEMI recognition on ECG, and direct transport to a PCI center improves survival.
But survival is generally low after out-of-hospital arrest if they remain comatose, right?
Unfortunately, yes, often less than 10%. Outcomes are better if the arrest was witnessed and the initial rhythm was shockable.
What if someone wakes up after arrest and does have a STEMI on ECG?
Interestingly, their outcomes are pretty similar to STEMI patients who didn't have an arrest.
Really?
Yeah. So, awake patients post-ROSC return of spontaneous circulation with STEMI are generally good candidates for primary PCI.
But for those who remain comatose?
It's much more individualized, need rapid assessment before deciding on invasive angiography. You have to weigh everything carefully.
Makes sense. And if they don't have ST elevation after arrest and are stable?
Then immediate angiography isn't needed. You can defer it pending further risk assessment.
Okay, that covers initial evaluation and risk. Let's get into treatment, the standard medical therapies for both STEMI and NSTE-ACS. Starting with oxygen. Seems basic, but what's the latest thinking?
It's actually changed quite a bit. Giving routine oxygen to everyone with suspected ACS, even if their oxygen levels are normal, lacks proven benefit.
Really? I thought more oxygen was always better in a heart attack.
That was the old thinking. But studies haven't shown a clinical advantage, and there's even concern it could be harmful, maybe constricting blood vessels or causing oxidative stress.
Wow. So what does the guideline recommend now?
Recommendation 1, CLD1, says supplemental oxygen is recommended if the patient is hypoxic oxygen saturation below 90%. The goal is to get it up to 90% or more, which can help oxygen supply and maybe reduce pain.
Okay, so only if they're actually low on oxygen.
Exactly. And recommendation 3, no benefit A2, is pretty clear. Routine oxygen in patients with saturation 90% or higher is not recommended because it doesn't improve outcomes.
No benefit and potentially harm.
Right. Some studies suggest worse outcomes with liberal oxygen use in non-hypoxic patients. There seems to be a U-shaped curve, with the lowest mortality around 94–96% saturation.
And trials like AVOID and DITO-2X-AMI confirmed no benefit.
Correct. DITO-2X-AMI was large, over 6,600 patients, and found no reduction in death or rehospitalization with routine oxygen if saturation was 90%. Avoid even hinted at increased heart muscle injury in some STEMI patients given oxygen unnecessarily.
Okay, that's a major takeaway. Only give oxygen if saturation is below 90%. What about pain relief? Chest pain is the classic symptom.
Yeah, rapid and effective pain relief is important to reduce that stress response, even if the analgesics themselves don't fix the underlying problem.
So nitrates, like nitroglycerin.
Yes, nitrates are still key. Table 6 discusses them. Sublingual or IV nitro for hemodynamically stable patients, systolic BP 90 or higher, can repeat sublingual doses.
Okay.
IV might be used if pain persists or if there's high BP or fluid in the lungs, but crucial precautions.
Right, need to avoid them in suspected right ventricular MI, low blood pressure, or if the patient recently took PDE5 inhibitors like Viagra or Cialis.
Exactly. That combination can cause a dangerous drop in blood pressure.
What about stronger pain meds, morphine or fentanyl?
They're usually reserved for pain that doesn't respond to anti-ischemic meds like nitrates, given IV in small, repeatable doses.
But there's a catch, isn't there, with the antiplatelet drugs?
Yes, a significant one. Opioids like morphine and fentanyl can delay the absorption of oral P2Y12 inhibitors, those crucial antiplatelet meds.
Like clopidogrel, prasugrel, ticagrelor.
Right, so if opioids are needed, doctors have to be aware of this potential interaction. And the main goal for persistent pain should still be restoring blood flow quickly, not just masking ischemia with opioids.
Good point. Let's talk more about those antiplatelet drugs. Aspirin first, still standard.
Oh, yeah. Aspirin has been a cornerstone of ACS management for ages. Its ability to stop platelets sticking together is fundamental.
And then the P2Y12 inhibitors, why add them?
They work on a different platelet pathway, blocking the P2Y12 receptor. Adding an oral one, clopidogrel, prasugrel, or ticagrelor, to aspirin forms dual antiplatelet therapy, or DDT.
And DDT is better than aspirin alone.
Significantly. Reduces major adverse cardiovascular events like MI, stroke, cardiovascular death. But the trade-off is an increased risk of bleeding.
Can you break down the different P2Y12s? Clopidogrel first.
Clopidogrel added to aspirin reduces MAE in both NSTE-ACS and STEMI, however they're treated. And in STEMI patients getting clot-busting drugs, fibrinolytics, it also improves survival.
Okay. What about prasugrel and ticagrelor? They're considered more potent.
They are. Compared to clopidogrel, they further reduce MACE and also stent thrombosis clots forming inside stents. This is seen in STEMI patients not getting fibrinolytics and in NSTE-ACS patients.
So potentially more clot protection, but maybe more bleeding risk too?
Generally, yes. The choice depends on the patient's individual risk profile.
What about the doses? The guideline gives specifics.
Yes, Table 7 had the details. For clopidogrel and PCI, usually 600 milligram below, then 75 milligrams daily. But if used with fibrinolytics and STEMI, it's a 300 milligrams load if he's 75 years old, then 75 milligrams daily. Over 75, just 75 milligrams daily, no load.
Okay, prasugrel.
Usually for PCI patients not getting fibrinolytics, 60 milligram load, then 10 milligrams daily if 60 kilograms and 75 years. Lower dose, 5 milligrams daily if 60 kilograms or 75 years, with caution.
And ticagrelor.
For NSTE-ACS or STEMI, no fibrinolytics. It's a 180 milligram load, then 90 milligrams twice daily. So specific doses and adjustments are important.
You also mentioned an IV P2Y12 option, cangrelor.
Yes, cangrelor. It's intravenous, works very fast, and wears off quickly. Platelet function back to normal within about an hour of stopping it.
When would that be useful?
If oral absorption is iffy, like if the patient is vomiting, or if they might need surgery soon after PCI where you wouldn't want a long-acting oral drug still on board, increasing bleeding risk.
Makes sense. Does it work well?
Studies comparing it to clopidogrel or placebo during PCI showed it reduced ischemic events around the procedure, but with a bit more minor bleeding. We don't have great data comparing it head-to-head with prasugrel or ticagrelor yet.
And you need to transition to an oral drug afterward.
Absolutely. Table 9 outlines how to do that, timing and loading doses for the oral P2Y12s after stopping cangrelor.
Okay, so cangrelor is more for specific niche situations. What about anticoagulants, blood thinners?
Also crucial. They help prevent new clots forming and existing ones growing. The guideline lists unfractionated heparin, enoxaparin, a low molecular weight heparin, fondaparinux, and bivalirudin.
And the choice depends on the situation.
Yes. Table 8 gives details on administration, dosing, and adjustments needed for kidney function, or whether they're getting PCI or fibrinolytics. It's another key part of the initial management.
We've covered anti-clotting meds. What about treating the underlying atherosclerosis? Statins.
Absolutely fundamental. High-intensity statin therapy is recommended for all patients without contraindications before they leave the hospital.
Yeah.
That's a strong recommendation, Class 1, Level A.
High intensity to really lower that LDL, the bad cholesterol.
Exactly. Lowers LDL by 50% or more on average. And tons of data, meta-analyses like the CTT collaboration, show this reduces major vascular events compared to moderate-intensity statins.
And starting it early after ACS helps.
Yes, trials like A to Z and PROVE-ITT-MY22 showed benefits emerge early and continue long-term, regardless of the starting LDL level. If high intensity isn't tolerated, moderate intensity is reasonable.
What if statins aren't enough to hit the LDL goal?
For high-risk patients, prior ACS, diabetes, etc., who still have high LDL despite maximal statins, the guideline discusses adding ezetimibe or PCSK9 inhibitors.
Based on trials like Improve It, Fourier, Odyssey outcomes.
Correct. Those showed further MPs reduction by getting LDL even lower, sometimes very low, seemingly without major safety issues like cognitive problems. The benefit is greatest in the highest-risk patients.
Okay, statins are key. What about beta blockers? Often started after an MI?
Yes, oral beta blockers are recommended early, within 24 hours, for patients without contraindications. Another strong Class 1, Level A recommendation.
Why? What do they do?
They reduce the risk of reinfarction, another heart attack, and dangerous ventricular arrhythmias, especially after STEMI.
I remember the COMMIT trials showed benefits, but also a slight initial risk.
Right. Metoprolol reduced reinfarction and VF, but slightly increased cardiogenic shock risk early on. So the approach is usually to start a low oral dose early, if stable, and increase gradually.
But stop them if heart failure worsens or shock develops?
Definitely. 5E beta blockers before reperfusion might be considered in stable patients with ongoing pain, but routine use before PCI isn't supported.
And how long do people need to stay on them?
That's still being studied, especially for patients with normal heart function after the MI. Ongoing trials should give more clarity.
Got it. Last group in this section, RAAS inhibitors, ACE inhibitors, ARBs. When are they used?
ACE inhibitors are recommended for patients with LV dysfunction ejection fraction of 40% and heart failure or diabetes post-MI. Another Class 1, Level A.
And ARBs if ACEs aren't tolerated.
Yes, usually because of cough. That's Class 1 BR.
And aldosterone antagonists.
Recommended for those already on an ACE inhibitor and beta blocker with LVEF 80-40% and either HF or diabetes if their kidney function is okay and potassium isn't high. Class 1 BR. They block that RAAS system, helping heart function and preventing remodeling.
Okay, that's a good rundown of the standard meds. Let's focus specifically on STEMI now. Reperfusion opening that blocked artery is paramount.
Absolutely. And the guideline stresses the value of regional STEMI care systems. Coordinated systems, faster treatment, better survival.
That's been shown consistently.
Yes, studies comparing outcomes before and after system implementation globally show clear benefits. Faster door-to-balloon times, improved survival.
But you mentioned a worrying trend recently.
Yeah, unfortunately, performance on meeting those time goals seems to have slipped lately, maybe partly due to COVID-19 stresses on the system.
So we need to keep pushing to maintain and improve these systems.
Definitely. Key components are public education, call 911, good data collection and sharing between EMS and hospitals, and regular meetings to review performance and fix problems. Figure 6 shows the pathway.
And the goal for patients calling 911 who go to a PCI center is?
First medical contact to device time within 90 minutes. Get that artery open fast.
Okay. So at a hospital that can do PCI, what's the preferred strategy for STEMI?
Primary PCI, or PPCI. It's the gold standard. Recommendation 1A1. Perform it within 90 minutes of FMC or within 60 minutes of hospital arrival.
That's the balloon and stent procedure.
Right. Catheter up, balloon inflated, stent placed to keep the artery open.
Is urgent bypass surgery ever the first choice for STEMI?
Yes, in specific cases. Recommendation 1A1 says urgent CAG is recommended for STEMI patients with, say, significant left main disease or complex multivessel disease not suitable for PCI, or if they remain unstable despite PCI.
Okay. But many patients might first arrive at a hospital without a cath lab. What then?
If they can't be transferred to a PCI center and get PPCI within the recommended timelines.
Which is ideally 120 minutes from FMC if transfer is needed.
Right. If that's not feasible, then fibrinolytic therapy clot-busting drugs is the way to go.
Okay. Are specific drugs recommended?
Yes. Table 13 lists the agents and doses, things like alteplase, radiplase, tenecteplase. Streptokinase isn't available in the U.S. anymore.
And there are contraindications, reasons someone can't get these drugs.
Absolutely. Risk of bleeding is the main concern. Table 14 lists absolute and relative contraindications like recent stroke, active bleeding, major surgery.
If fibrinolysis is chosen, how quickly should it be given?
Within 30 minutes of hospital arrival, the door-to-needle time, that's recommendation 1A1 for eligible patients. Time is muscle.
What happens after getting the clot buster?
Recommendation 1A1 also advises routine coronary angiography and PCI within 24 hours. This applies whether the fibrinolytic worked well, didn't work well enough, or if the artery recloses. Need to check the arteries and potentially stent the culprit lesion.
Okay, that covers STEMI reperfusion. Now, shifting to NSTE-ACS, the initial strategy seems different, invasive versus selective.
Right. For NSTE-ACS, an early invasive strategy angiography, relatively soon, with intent to revascularize PCI or CABG. If needed, generally reduces death and MI compared to a conservative approach.
So who gets that early invasive strategy?
Recommendation 1A1 says it's for patients with high-risk features. That includes elevated troponin, significant ECG changes like ST depression, hemodynamic instability, heart failure signs, or a high STEMI risk score. Figure 8 helps guide this decision.
And what about NSTE-ACS patients without those high-risk features?
For them, a selective invasive strategy is recommended. Recommendation 1BR2. Angiography isn't automatic. It's guided by whether they have recurrent symptoms or if non-invasive testing, like a stress test, shows high-risk findings later on.
Got it. Let's go inside the cath lab now. Any specific considerations when doing procedures on ACS patients, like how you access the artery?
Yes, vascular access is important. Recommendation 1A1 strongly prefers using the radial artery in the wrist over the femoral artery in the groin for PCI and ACS.
Why the preference for radial?
Less bleeding, fewer vascular complications at the access site, and studies suggest maybe even lower mortality in ACS patients. Plus, patients tend to like it better. Less discomfort, earlier ambulation.
Makes sense. Any downsides?
Need to consider if that radial artery might be needed for future bypass surgery, though. Transfemoral access, ideally with ultrasound guidance, is still needed for things like temporary mechanical support or when radial isn't feasible.
What about aspiration thrombectomy, sucking out the clot before stenting?
The idea was appealing remove clot, improve flow down the vessel, but routine manual aspiration thrombectomy before PCI hasn't panned out in large trials.
It didn't improve outcomes.
No. Several RCTs and pooled analyses showed no reduction in MI size or clinical outcomes compared to PCI alone. So, recommendation 3. No benefit A1 advises against routine use.
But maybe in specific situations, like a lot of clot.
Possibly. The guideline mentions bailout thrombectomy might be performed for persistent large thrombus after angioplasty or stenting, especially with no reflow, but it's not routine.
How about imaging inside the artery during PCI? IVUS or OCT?
Intracoronary imaging. Recommendation 2B BNR1 suggests it may be reasonable after angiography to optimize stent deployment in selected patients. It gives a much more detailed view than angiography alone.
Okay. What about patients with blockages in multiple arteries, multivessel disease during ACS? How is that handled? First, in STEMI.
In hemodynamically stable STEMI patients with multivessel disease, after the culprit artery is successfully opened, recommendation 1A1 recommends PCI of other significantly blocked non-culprit arteries.
Treating the other blockages too. Why?
It reduces the risk of death, or MI, and improves angina-related quality of life. This is usually done either during the same procedure or as a planned staged procedure before discharge.
But not for everyone.
Right. Applies to stable patients suitable for PCI. If they have very complex disease, especially involving the left main or LAD, elective CABG might be reasonable instead. Recommendation 2A CEO2.
And there's some debate about doing it all at once versus staged.
Yes. Recommendation 2B BR3 suggests multivessel PCI at the time of PPCI might be preferred over staging in selected stable patients with lower complexity disease, not needing CABG, to reduce cardiovascular events.
Okay. How about multivessel disease in NSTE-ACS?
In stable NSTE-ACS patients with MVD, recommendation 2A ER1 says PCI of significant non-culprit lesions may be reasonable before discharge.
Maybe using physiology assessment like FFR to guide decisions.
That might be considered, yes, recommendation 2B BR3. But a crucial point, routine PCI of non-culprit arteries in NSTE-ACS patients complicated by cardiogenic shock is harmful.
Harmful? Why?
Recommendation 3. Harm BR4 strongly advises against it because it increases the risk of death or kidney failure. In shock, just fix the culprit lesion.
Let's stick with cardiogenic shock, such a serious complication. How is it managed in ACS?
The absolute priority is emergency revascularization of the culprit vessel PCI or CIBG. Recommendation 1BR1 says this is indicated to improve survival, regardless of time since symptoms started.
Get blood flow back to stop the downward spiral.
Exactly. But again, recommendation 3. Harm BR2 reiterates not to routinely fix non-culprit arteries in shock due to increased risk of death or renal failure. Just the culprit.
Are mechanical support devices helpful in shock, MCS?
It's complex. Shock happens in maybe 10% of STEMIs, high mortality. Devices like IABP, microaxial pumps like Impella, VA ECMO exist, but efficacy is variable, and they carry risks, especially vascular complications.
So what does the guidelines say about using them?
Based on the recent Danger HA-YAWN trial, Recommendation 2A-BR1 says a microaxial intravascular flow pump is reasonable in selected STEMI patients with severe or refractory shock to reduce death.
That's a specific recommendation, but there were caveats in the trial.
Yes. While it reduced mortality, it also increased complications like bleeding, limb ischemia, and need for renal replacement therapy. So, careful patient selection, attention to access site, and careful weaning are crucial.
What about IABP and VA ECMO? Routine use.
Not supported by trials like IABP Shock 2, ECMO CS, ECLS Shock. They showed no mortality benefit, and VA ECMO ACS had increased complications, so routine use isn't recommended.
But maybe MCS is a bridge.
Yes. Recommendation 2A BNR2 says short-term MCS is reasonable for hemodynamic stabilization as a bridge to surgery in patients with mechanical complications of ACS.
Let's talk about those mechanical complications. Tears, valve issues.
Right. Ventricular septal rupture, papillary muscle rupture causing severe mitral regurgitation, free wall rupture. Less common now with early reperfusion, but devastating when they happen.
How do they present?
Usually within the first week post-MI. Recurrent pain, new loud murmur, sudden worsening heart failure or shock, much worse than expected.
And medical therapy alone isn't enough?
No, high early mortality. Surgical correction is often needed. But surgery itself is very high risk, especially in shock or if done emergently.
So what's the trend? Delay surgery?
There's a trend towards trying to stabilize patients first, often with temporary MCS, and then doing surgery later, potentially allowing tissue to heal a bit. But the optimal timing is uncertain.
What's the recommendation for managing these?
Transfer to a level 1 CICU with full capabilities and a multidisciplinary team. Cardiac surgery, interventional heart failure experts is recommended. Recommendation 1, CEO1. A heart team approach is key to decide on timing, surgery type, MCS use.
Okay. What about electrical complications? Arrhythmias?
Big risk after ACS. The guideline mentions monitoring, telemetry, and potential interventions like antiarrhythmics or defibrillation and the risk of sudden cardiac death, but doesn't dive super deep into arrhythmia management itself.
And pericarditis, inflammation around the heart.
Mentioned as a complication. Tables 18 and 19 cover diagnosis and some therapy aspects, but again, not detailed management in this guideline.
Left ventricular thrombus, clot in the heart chamber.
Also briefly mentioned as a potential complication needing management, usually anticoagulation.
Okay, let's shift to in-hospital care issues.
Yeah.
Where should ACS patients be? CICU.
Patients with ongoing angina, instability, arrhythmias, suboptimal reperfusion or shock should be in a CICU. Recommendation 1, CEO1.
For closer monitoring and higher level care.
Exactly. Stable patients without those issues might go to intermediate care or telemetry units. Risk scores like the ASEAN ICU score can help identify who needs CICU level care.
What about anemia?
Low blood count. Recommendation 2B-BR1 to just transfusion to aim for hemoglobin E10 GDL may be reasonable in ACS patients with anemia to reduce cardiovascular events. It's a maybe reasonable.
Telemetry monitoring duration. Length of stay.
Mentioned briefly, but highly individualized based on clinical course and complications. No fixed rules.
Any routine non-invasive tests before discharge? Stress test, echo.
Possible, but not routinely recommended for everyone. Depends on the clinical situation and physician judgment.
Discharge planning sounds incredibly important for preventing bounce backs.
Hugely important. Patient education is key for behavior change and better outcomes. Table 20 lists essential topics: diagnosis, lifestyle, meds, follow-up.
And readmissions are a big problem.
Yes, about 1 in 5 readmitted within 30 days. Higher risk for women, underrepresented groups, ICU patients. Quality improvement programs and transitional care interventions are vital. Table 21 gives best practices for discharge.
Cardiac rehab often gets recommended. What's the guideline say?
Calls it standard of care for secondary prevention. Modifies risk factors, improves function, quality of life, reduces morbidity and mortality. It's comprehensive. Exercise, education, support,
But it's underutilized.
massively underutilized, especially by women and certain groups. Referral rates are often low.
So refer early.
Yes, referral during hospitalization before discharge is recommended to boost uptake.
What about home-based rehab?
Recommendation 2A-BR2 says home-based CR is a reasonable alternative to center-based, especially for rural patients or those with access issues. Similar short-term outcomes. The main thing is getting enrolled and adhering to any program. Digital health tools might help too.
Okay. Now for a big topic, duration of antiplatelet therapy after ACS, DAP.
Right. DAP, aspirin plus P2Y12 inhibitor definitely reduces thrombotic events post-ACS, no question.
But the downside is bleeding.
Exactly. Longer DAPT means more bleeding risk. And bleeding can lead to stopping therapy, which then increases clot risk. It's a balance.
So how do you decide how long?
Trying to identify who benefits most from longer DAPT versus who could stop earlier to minimize bleeding. Risk scores for ischemia versus bleeding can help personalize this.
Are there new strategies being explored?
Yes. A big one involves stopping aspirin after 1 to 3 months and continuing with ticagrelor or monotherapy.
Just a cochlear. How does that look?
Studies suggest less bleeding compared to continued DAPT without a clear excess in MACE. Figure 11 shows these strategies.
What about clopidogrel monotherapy after short DAP2?
Data is more mixed there. Some concern about increased ME risk compared to longer DAPT, maybe due to variable response to clopidogrel.
And stopping the P2Y12 inhibitor early and staying on just aspirin.
Trials show that increases thrombotic risk if done around 3 to 6 months after PCI for ACS.
So the trend seems to be towards potentially shorter aspirin duration with potent P2Y12s like ticagrelor in some patients.
That seems to be where evidence is heading, yes, to reduce bleeding. But using prasugrel monotherapy early isn't well established and might even be harmful in some settings.
What about patients who also need long-term anticoagulation for AFib or clots?
That's complex. Triple therapy, aspirin, P2Y12, anticoagulant has very high bleeding risk.
So you have to adjust.
Yes. Growing evidence supports stopping aspirin early, often within 1 to 4 weeks post-ACS PCI, in patients needing long-term anticoagulation.
And which anticoagulant? Which P2Y12?
Generally, a DOAC is preferred over warfarin. And usually clopidogrel is the P2Y12 inhibitor chosen in this setting, because prasugrel ticagrelor weren't well studied with anticoagulants. Then decisions beyond 12 months fall under chronic coronary disease guidelines.
Okay. A couple of select other therapies mention colchicine.
Yeah, an anti-inflammatory. Some studies, like LOTO-CO2 and stable CAD, including prior ACS, suggest low-dose colchicine might reduce MACE-E, possibly by reducing inflammation.
But not universally recommended yet.
Not quite. Results are a bit mixed across trials, though pooled analyses look promising. There are contraindications too: blood disorders, severe kidney liver issues, drug interactions. Ongoing studies are looking into it further post-MI.
And immunization, flu shots.
Yes, recommendation 1A1 strongly recommends annual influenza vaccination for ACS patients without contraindications.
Because it helps.
Yes, studies like FLU-VACS show it reduces death and ME. Giving it soon after an event or procedure seems beneficial.
Finally, the guideline mentions evidence gaps and future research. What still needs work?
Several areas. One big one is better defining that transition from acute ACS to chronic coronary disease. It's fuzzy now and impacts decisions about de-escalating therapy.
Makes sense. What else?
Optimizing MCS and cardiogenic shock. We have the danger SH use result from microaxial pumps, but it came with increased complications. We need better ways to select patients, time device use, and reduce risks associated with MCS.
Lots still to learn. Okay, that was a really thorough journey through the 2025 ACS guideline. To wrap up, what are the absolute top 5 takeaways for our listeners?
All right, let's distill it down. 5 key points. 1, early ECG and rapid triage are paramount in suspected ACS, especially STEMI. Time is critical.
Absolutely. Get that diagnosis and plan fast.
2, routine oxygen is not beneficial and can be harmful if oxygen saturation is normal, 90%. Only use it for hypoxia.
Big change from old practice.
3, high-intensity statin therapy is a cornerstone post-ACS for almost everyone. Start it before discharge.
Lower that LDL, reduce future risk.
4, for STEMI, PPCI is the preferred reperfusion strategy if you can get it done within the guideline timelines. 90 minutes from FMC, 60 minutes from hospital arrival.
Open that artery quickly and effectively.
And 5, duration of DAPT is evolving. Consider shorter aspirin duration with ticagrelor monotherapy in some cases to cut bleeding risk.
Balancing clot prevention and bleeding is key.
These guidelines really underscore the need for speed, evidence-based care, and a systems approach for ACS.
They really do shape high-quality cardiovascular care, and we definitely encourage you, the listeners, to check out the full guideline on the ACC and AHA websites if you want even more detail.
Yes, and always discuss any personal concerns or questions with your own healthcare providers.
Of course.
So, a final thought to leave you with. As we get better at understanding individual patient risk and the subtle differences between antiplatelet therapies, how will these personalized approaches continue to reshape ACS treatment in the coming years?
Great question. It's constantly evolving.
Thank you so much for joining us for this deep dive into the 2025 ACS guidelines.
We hope it provided clarity on this vital topic.
We'll catch you next time on The Deep Dive.